my pleasure today to introduce our panel and to give you a little bit of background about what we're going to be doing in the next 40 minutes or so. So last year we developed a video because we realized that it would be much easier to capture people on video than to try to get people from all over the country who have no idea who we are to come here and hang out with us for a few days. And so we did that again this year. One thing I'll say about the video, and I think one thing we've learned, and we talked about this at breakfast, is that it's very difficult, even though it may seem like everybody wants to talk about their experiences, it's very difficult to identify people and get them to agree to be on camera. Not everybody's comfortable with that, and we've also learned that just like everything else we're working on around trust, that it really depends on who invites them, who they know, and what we tell them about how whatever they share with us is going to be used to make healthcare better. So before we get started and before we show the video, I want to encourage you to read their stories because there are some important things that don't necessarily jump out of the video, but that put some of their remarks in a better context, I think. And I also, when I read the background paper, there were several points that jumped out at me that I think are relevant for this session. So I'm just going to share a couple of those with you. So one mistaken belief or bad encounter with a provider can have a lasting impact on how entire generations either trust or distrust healthcare professionals. Another one that is near and dear to my heart, the first one is very much so, is expecting physicians or other healthcare professionals to address misinformation without any training is contributing to burnout. And we know that's true. Everyone in this room, I think, knows that's true. Helping patients who've been influenced by misinformation is often a multi-visit process to offer respectful and nuanced responses to false claims and to establish a trusting relationship, which, at least in my world, where our capacity is more limited than I've ever seen it in my entire career, and the needs are greater because of people deferring care and whatever. This is a challenge, but it's a very important one if we want to make a difference over time. Cultural humility is critical, and that's something I think we're all learning about and learning to hopefully do a better job with. And then finally, Dr. Robert Califf's quote at the end of the paper was very sobering, that he considers misinformation and lack of trust to be the leading cause of death in this country. So with that, I want to introduce our wonderful panel. Dr. Mercy Adetoye, who is a clinical assistant professor in the Department of Family Medicine at the University of Michigan. Go Blue. Meg Gaines, who is a lawyer, is the founder of the Center for Patient Partnerships at the University of Wisconsin. And finally, Dr. Jeanne Marrazzo, who is the Glenn Cobb's Endowed Chair of Medicine and Director of the Division of Infectious Disease at the University of Alabama at Birmingham. And now we're going to show the video, and we're going to be hearing from Lydia, Hannah, Sondra, and Sherry.
Having breastfeeding troubles with my daughter and then having the doctor just say, don't be so brokenhearted if it doesn't work out, but not offering me solutions to my issues also left me a little jaded. And then I think that last encounter where my daughter was having a crying episode and I was brushed off was the final straw, where I was pushed into the arms of the anti-vax movement.
I lost trust in my GI surgeon when he flat out told me that he didn't believe me when I said that I thought I had another condition going on. I went in knowing that I was going to get a bowel resection, and I asked to have a GYN present because I suspected endometriosis as well. And he said, "You don't have two things." And And that was just a very clear instance of him not even bothering to think about what I was saying or how that would impact me.
This past October, I had an appointment with my primary care physician where we agreed that I needed quite a few referrals. Over the next 4 or 5 months, I called the office to inquire about the status of those referrals. By February, when my follow-up appointment approached, I was livid. I went to this appointment loaded with anger and frustration that I had not gotten the referrals that I needed, and here I was already at the follow-up appointment.
Well, after the surgeries, the whole crew of doctors would come in every morning, 6 o'clock in the morning, and you would have like 9 doctors standing around your bed, and they're all asking questions and taking notes, but they're not telling me anything. And my family is obviously not there. My husband was there a lot of the times because he stayed every night with me in the hospital, just about. But they need to communicate differently, and I just had no clue what was going on.
The sources I used to validate my choices in not vaccinating came from an online forum, and it was a forum for attachment and natural parenting. Following that, I also started reading books by physicians, by pediatricians who also were spreading vaccine disinformation. And then later, of course, Facebook came, and Twitter and all of that, which started to really spread the disinformation around. I trusted those sources because the groups listened to my concerns, and there was a sense of community and caring that I didn't get from when I needed it most.
Yeah, I've had a couple of experiences losing trust. I was diagnosed at a fairly young age with Crohn's disease, and I think that first interaction is probably one that stands out to me the most. So when I was around 10 years old, I started experiencing symptoms. I was always tired. I was never very hungry. I was losing weight pretty rapidly. I was losing interest in activities. And I would get constant stomach aches and very often had throat infections that were never strep. And my parents brought me to the doctor, and time and again, I was told an excuse for those symptoms. So I was told that I was just an anxious kid, and that's why I was having stomach aches. I was told that the scale must have been broken, that I probably didn't lose that much weight. All kinds of different things that not only made me lose trust in my doctors and in the medical system as a whole, but really caused me to lose trust in my own body and in trusting myself and what I was feeling. Because it was at such a critical age, it was a hard thing. And so that went on for a number of years, despite symptoms like blood in my stool and things like that. Finally, I was referred to an endocrinologist who did some blood work that showed that I was severely anemic. I was hospitalized. I had an emergency scope, which showed very clearly that I had Crohn's disease.
I work for a public health agency, and we often talk about disparities in healthcare and outcomes for BIPOC communities. This is usually associated with minority communities, but more often poor communities. And here I am experiencing such the same disparity, even with insurance and the ability to pay. And so I was frustrated with my primary care physician and my expectation of good health care.
I've denied a lot of treatments because of the payment plan and the money I have to pay out. I'm supposed to be followed by a dietitian because staying healthy with no colon and maybe 2/3 of your intestines is difficult. And I'm supposed to be followed by a gastroenterologist. My regular doctor just wanted to do a liver test because my liver enzymes are really high, and they have been since the surgery. But that test is $500, so I declined it. I declined a lot of medical because I can't afford it. I really feel that the hospitals should communicate more with their patients and with the loved ones, and not only about the health care that they're given, but the amount that it's going to cost. And a lot of people say that, money's no problem, but when it comes down to millions of dollars, it does count.
Healthcare providers can help the situation by listening. And I know that seems hard when we don't have a lot of time at appointments, or we want to just cut off the misinformation without hearing them out because it sounds so ridiculous sometimes, But listening is how you gain trust. So at that appointment, listen, if you don't know the answer at the top of your head, you can say you don't know. That actually helps build more trust. If you say, wow, that sounds scary. I don't know the answer, but let me look into that for you.
Communication is the largest forerunner to trust. I don't think doctors today have a lot of time or energy to communicate directly with patients. I will tell you that in my experience, my absolutely best doctor-patient relationship has been with doctors who personally took the time to call about test results and recommendations, and you just don't see that anymore.
I think even within a 15-minute appointment, there's a lot a clinician can do. Even as simple as making eye contact, a warm smile, letting them know that they're there and present and not distracted by other things. Those small things go a really long way in showing a patient that you care and you're there and present and wanting to hear them. Asking open-ended questions like, did we cover everything you wanted to today? Things like that. Even if there's not time, it's okay to say, let's make another appointment to talk about that. Being realistic and setting real expectations of what someone can expect next.
I suffer from PTSD with hospitals because of all I went through. So anytime I go to the hospital, I never had anxiety problems, and I do now.
So we're going to have a discussion here, and then we're going to have a little time for questions and answers. But I'm going to start with Meg to sort of share sort of what you heard here, what struck you with these interviews.
What struck me the most, both the first time I watched them and this time, is how powerful all four of those women are. Each of them in her own way, despite in some cases lack of formal education or resources or whatever. I think they all have this unmistakable kind of life force and self-trust. And what really strikes me is how we leave in the professions, and I will speak for my own also, we walk in assuming that we have expertise and therefore that needs to be applied somewhere. And it just struck me that with all four of those women, if someone had walked in and said, you have expertise, how can I help? What a difference that would have made. So to me, the question is a little bit off, because I'm not sure it's all about misinformation or not how can we get patients to trust clinicians? I think it's more, how can we get clinicians to trust patients? Because I'm my own primary care doctor 99.9% of the time.
Thank you. Mercy.
A lot of things struck me with the conversations. The patient Lydia, who she has a background in science and still was pushed into the anti-vax movement because she didn't feel that sense of community with her healthcare clinician. That piece of, how do I communicate as a professional in a way that you understand that I am here for you, here to take care of you. I also think a lot about, as the patient population is changing, becoming more diverse, are we as physicians, is that population becoming more diverse? Because we know if there's some sort of congruence with your healthcare provider, we can increase healthcare outcomes. The other piece is, what if the big bad scary thing is coming from inside the house? Lydia says that she was reading pediatricians' books that were pushing disinformation. What are we as a profession doing about that when we have to look at ourselves and really think about professionalism, protecting patients? How are we addressing those actions?
Yeah. And I think Lydia, in the story, Lydia makes a comment about having trouble with breastfeeding, and her doctor just sort of blew it off and like, well, why don't you just use formula? And then she was able to go to a lactation consultant and get all the help she needed, which is incredibly important for a new mom. So,
as a new mom, that struck me. I would have sent an email, and would have been bad. So yeah.
Yeah. So Jeannie, I know you had strong feelings.
Well, I was completely blown away by these videos, and I feel like it could take us days to unpack them. I mean, really, it could be the whole forum. We could just sort of really sit around and have structured discussions about these 4 videos. I would say 2 big areas. First of all, the concept of imprinting and how important first encounters are, particularly when you're really vulnerable. The woman with IBD and endometriosis talked about being very young and being dismissed as anxious and maybe, having a little bit of a weight loss disorder thing, but, just not even having the sort of being believed at that age. That already sets you up, as has been mentioned before, for really not trusting future interactions. And so I think impressionability and durability of those first impressions, whether it's with a provider, with a system, for a particular problem, really came through very strongly there. The other thing that I think I found remarkable was that so much of the disconnect involved the differences between the healthcare provider and the patient. And the most obvious one here was gender, right? I mean, I don't know, at least 3 of the providers were mentioned as he. And maybe that's one of the most obvious ways that we can be different, but it's just a reminder that it's really hard for us to understand people who aren't like us biologically, behaviorally, socioeconomically. And that sometimes is in spite of our best efforts. But the whole idea that you would have a provider who doesn't understand what it's like to breastfeed, to menstruate, to have a baby, all kinds of things, and then to be dismissed because of your anatomy not being the same as that person and not having that same experience, that really came through very strongly to me.
Great. One of the things that struck me was the young woman who knew she had endometriosis and wanted a GYN surgeon in the operating room, and the doctor tells her that, no, you can only have one disease. I'm like, oh, really? But Mercy, I'd love your thoughts about that, and how do we address sort of what I think of as the tunnel vision. If you don't fit into what I've know from my book learning, then it can't be right. I can't trust you. I have to trust what I've read about or what I've been trained. So can you speak to that?
I think it does go back to medical education and training. If we can not just have MDs trained together, pharmacists trained together, PAs trained together, but you think about the entire healthcare team. If you have diversity at that table, hopefully with that medical education, it'll help when you become the attending the clinician to really broaden your perspective, but it has to start early, because once you're in residency, we learn our algorithms really quickly because we have a lot to do in those 80-hour work weeks. And so if we can start with medical education, working as a team, thinking about it, that I won't be able to do this on my own, getting various perspectives, that'll be a great mind map for us in the future.
Great.
Yeah.
Meg, I'd love to hear from you about where I want to move to sort of what are some of the things we can do to mitigate some of these problems? And from your perspective as a patient, what have you learned in your interactions with clinical teams, care teams, where you have some influence and agency and you're not just a passive person at their mercy?
Well, one of the most recognizable attributes, I think, of a relationship that's collaborative, of a strong working relationship on a team where patient is the, is the captain, or at least an important member of the team, is, I think, the goals are different usually, because the actual subject of the care gets a role, a critical role, a leading role in describing and defining the goals of care. And I think it's remarkable, and in all these cases you see it, how the train leaves the station bound for a destination that the patient doesn't want to go to. Or the patient says, but I have a ticket for, help with breastfeeding, and you're taking me to, I don't worry about it, formula will be fine. That's not a destination I bought a ticket for, and I don't want to go there. And so it very quickly diverges and I think high performance teams wouldn't dream of leaving the station without a shared understanding of what the goals are. And that seems so basic. The older I get, the more I think, when I teach communication, I most of what I do, and maybe it's because I teach a lot of lawyers too, but is to tell people to stop talking so much and just say things that sound stupid, right? Say things like, wow, that sounds really hard, or gosh, I'm so sorry that happened. And the students all look at you like, I can't just say that. That sounds so stupid. Right, and emotional and whatever else, but it sounds so stupid, like I got to say something smart, right? And it's just so simple,
And Jeanne's anxious to say.
No, not anxious. I was just going to build on something both of you said, and I think we shouldn't leave this discussion without talking about the power of role modeling this as a teacher, an educator, a physician. So I'm thinking about the tale of being rounded on at 6 o'clock in the morning by 9 people, 10 people. How many of us lived that on a daily basis during all of our training? And how many were in situations where the patient was engaged, awake, present, and taught? No, not at all. That's really changed. I mean, it's not perfect. You still have exactly what she talked about, but at least in the way that we do it now, bedside rounding is much, I think, better, certainly engaging the patient. And so being sure that as you're leading these teams, as you're leading the interdisciplinary teams that you both talked about, that you really role model that and make sure that that is the standard that you want to see going forward is really critical. So I have hope for that.
One of the things I think we've been blessed with in Massachusetts is that we've had a state law that we have to have patient-family advisors in all of our hospitals. And they, at Mass General, we have 11 formal patient-family advisory councils and then dozens of other patient advisors that educate our clinicians, that advise us about a million different things. And one of the most important things I think those partnerships create is a much stronger sense of respect, if not awe, of what patients go through to manage their own illnesses, to get the care they need, that is largely invisible to us. We just see them once they've walked through the door. And it makes all the difference in the world in understanding and knowing, I think, better how to sort of define those partnership relationships that are very powerful. But Mercy, I'm going to see if you have other comments here.
So a couple of things I wanted to make sure we touched on was physician, clinician, healthcare, wellness, and burnout, and how that plays a role in all of this, right? So the expectation of seeing patients every 20 minutes, et cetera. So taking away from patients, we are the face that patient sees. And I do think that every institution, organization, industry, academics, et cetera, should have a chief wellness officer, even if just in name, to say that it is important, so that we can keep the joy and practice at the forefront. Yeah, because we do have to take care and think about our clinicians as well. One story, Sondra's story about navigating the administrative part of healthcare. As a primary care physician, I understand the referrals and thinking about prior authorizations, et cetera. What I loved about that story was that her primary care physician allowed her to emote and to express her feelings, recognized it, and also apologized for what happened. That is a small way that you can continue to build trust.